Good morning, all. Yeah, the common causes would be in babies who are born within the first 72 hours. The common causes transient tachypnea of the newborn. Then babies can have all kinds of aspiration syndromes, meconium aspiration, amniotic fluid aspiration, or blood aspiration. Then these babies can also have a etiology like onset of pneumothorax, and babies who have had severe asphyxia can actually present like babies with hyaline membrane disease, and babies with infants of diabetic mother also can have relative surfactant deficiency and can develop respiratory distress. So most of these presentations will be within the first 6 hours, and for babies between 6 to 24 hours, again the aspiration syndromes are common. Then congenital pneumonias also can present with respiratory distress. But after 24 hours of life, and when the baby starts new onset respiratory distress, you have to think about more of acquired pneumonias and pneumothorax.
Yeah. So point well taken, sir. So we need to decide and think about at what age of life, at what hours of life that respiratory distress has begun. So definitely on basis of a differential, and prioritizing our differential will help us to lead to proper diagnosis in distress in term babies. So I would like to ask, what are the common causes of respiratory distress within 72 hours life in preterm baby, Dr. Fadil?
In preterm babies, RDS, then TTN, then congenital pneumothorax, congenital pneumonia, uh, other malformations, then aspiration syndromes, amniotic fluid or blood aspiration, congenital heart diseases, which are drug dependent, or PDA.
Absolutely. These are the common causes in preterm also. So we can divide on basis of within 6 onset of a distress within 6 hours. They are definitely different from term babies, and they are prioritized in the differential is also important in them. So another question to Dr. Samit, that what are the common causes of respiratory distress which will persist beyond 72 hours in preterm as well as term babies?
Yeah, respiratory distress persisting beyond 72 hours in a term baby. Common causes are respiration syndromes like meconium aspiration syndrome, sepsis, pneumonia, pneumothorax, congenital heart diseases, then lung malformations like CCAM, CPAM, pulmonary hypoplasia. Even TTN can persist beyond 72 hours of life. In preterm babies, the most important cause is respiratory distress syndrome, followed by sepsis, pneumonia, pneumothorax, congenital heart disease, and lung malformation.
These are the causes that when you need to understand if a respiratory distress getting resolved within 72 hours. That means all the respiratory distress, if you form a differential of 3-4 differentials, and if a baby is not getting resolved beyond 48 72 hours, then you need to what you call reprioritize, resequence your differentials in them. Now we have done up till now what are the causes of respiratory distress within 72 hours. But if a baby is having respiratory distress beyond 72 hours, definitely HMD, that is RDS, will not be a differential diagnosis. Definitely meconium aspiration will not be a differential diagnosis. Definitely primary pulmonary hypertension will not be a differential diagnosis. So I would like to ask Dr. Boone, what are the causes of common causes of respiratory distress if a baby is having if he is having onset after 72 hours, like both in preterm as well as term babies?
Yes, it is the time where pediatrician and neonatologist have to think and tell the parents जो अभी तक तो अच्छा था और अब नया क्या हो गया है. So we have to think the new causes that present after 72 hours. Mostly, first we always think of the sepsis that increase the workup with the patient having tachypnea because of acidosis. Secondly, we should think about the congenital heart disease that present after 72 hours, mostly PDAs and left apolastic ventricles that can present after 72 hours. Along this, I should think about the IEM, involuntary of metabolism, and some lung masses should be there. Pneumonia, where viral or bacterial pneumonia can be present after 72 hours of the age. Or those patients are admitted and taken any drugs, so any drug reaction can increase the work of breathing and patient can start with the respiratory distress.
Absolutely, sir. The point well taken. So respiratory distress in them could be cause of various other differential apart from what we have discussed, which are having respiratory distress onset within 72 hours of life. So this question is to Gunait, sir. Sir, you are going to your PNC round, you find a day 3-old baby having tachypnea and lethargy. The first very early thing which comes into our mind is sepsis, but sepsis is very quite rare in PNC ward. However, our differential then moves from congenital heart disease है या फिर inborn error of metabolism है. So sending a panel of investigation, we need to prioritize our investigations. How to prioritize? What will lead us to think this is could be a higher chances of congenital heart disease, and this could be we should think towards IEM in such kind of babies. So how to prioritize our investigations?
Right. And it's always dreadful to find a very sick baby in PHC ward. But congenital heart disease will have a presentation, most of them, if they are getting so sick, they will have cyanosis with or without a cardiac murmur. But they will again have, if there is pulmonary hypertension developing or there is pulmonary overload, then they will also have respiratory distress and tachypnea. So that's a bit of clinical differentiating feature. While babies with IM as a group, the presentation depends quite upon what is the exact enzyme deficiency and what degree of enzyme deficiency is there. But as a group, they still will have a presentation which is more of neurological, like poor feeding, poor bone, and absent suck, or they are not able. Sometimes they present with seizures also. So that's a basic clinical difference we can have. And in terms of investigations for congenital heart disease, you should also do an immediate pulse oximeter testing for both pre-ductal and post-ductal saturation. And for IEMs, you have to do a panel of tests, screening tests, which are, you should do a lactate, you should do an ammonia, send an ammonia quickly, do a blood gas to find out if there is acidosis, and you should also look for urinary and blood ketones. So that's how I go about finding out.
Okay. So up till now we have learned causes of a respiratory distress starting beyond 72 hours, within 72 hours. So let's test our knowledge and let's solve this case. So this was a preterm baby born with after IVF conception with 28 to 30 weeks of gestation. Mother was an elderly primary gravida, was having PIH, controlled GDM, was singleton pregnancy. There was a history of leaking PV since last 3 years without labor pains. Emergency LSCS was done, no antenatal steroids were given. Baby required intubation after birth for stabilizations. Baby was shifted to NICU with birth weight of 1.1 kilo. At NICU, baby was put on ventilator support. Ventilator support settings were quite high, with PIP of 20 and PWP 7 was required. FiO2 of 60% was given. Surfactant was given within 1 hour of life, as there was minimal response in ventilator setting. Second dose was also needed. Gradually, ventilator settings were reduced to 10 by 5, 30% of fat. So meanwhile, feeds were started on day 3. Baby was on partial feed and partial fluid on day 3. No antenatal support was given. So Dr. Sabir, you thought this baby we will extubate tomorrow morning. आज तो देख लिया, कल morning में थोड़ा सा और stable होके we will extubate. But you receive a call from your resident doctor, middle of the night, the baby is not saturating, really saturating 60 to 70. 60. So what could be the cause in this such a scenario?
In such cases, when an intubated neonate deteriorates suddenly, we should rule out 4 causes first, given by the mnemonic DOPE, D-O-P-E. D for D-O-P-E. D for dislocation of tube. The tube might be discharged out of the trachea or displaced further in either of the bronchus. O for obstruction, which may be caused due to secretions, mucus plug, blood clot, or kinking of the tube. P for pneumothorax, triple pneumothorax, or tension pneumothorax. E for equipment failure, like disconnection of O2 connection, then power supply failure, then leak from the circuit. So in such cases, first we should put the baby on AMBU, start bagging, and look for chest rise. Look whether the saturation is increasing. Also, we should check whether the ventilator is functioning properly or not by connecting a test lamp. So if there are secretions, suction, if the tube is blocked, then change the tube. If the tube is out or displaced, change the tube. If still there is no chest rise or the baby is not improving, we should do an urgent chest X-ray to rule out pneumothorax.
Yeah, these are all points we need to think about the moment we receive a phone call from a resident doctor. A resident doctor may be compatible, may not be compatible for re-intubation and for intubation all. So on phone call, what are the sequence of event you're going to ask? Why to test lung first attach kar le and take the baby on ambu. You see the chest rise, his chest rise is okay or not. After doing the ambu, whether there is increase in saturation or not. If this thing is not there, do a proper suctioning and then see if ventilator is functioning properly or not. Now, even after that baby is not maintaining saturation, while you reach to the NICU, you have to say if saturation is not well, you need to order an X-ray. Why? Because equal air entry doesn't always mean that you have ruled out pneumothorax. Because of a small chest, oscillatory sounds they get easily transmitted from one area to other. It's very difficult to differentiate whether there was pneumothorax or not. So after ruling out dope in this patient, this is in this preterm baby, we found that this baby actually needs higher ventilatory setting to recruit the lung, to get the oxygenation properly. So Dr. Bhupesh, what could be the possible causes in such kind of scenario?
As after excluding the common things and baby is premature 1.1 kg, 29 weeks, and now he is requiring higher settings. So most common is the large size PDA that we should exclude in that baby because after the increasing the PEEP and this, and why should we like to do the ABG and X-rays? In X-ray, we will see the cardiomegaly and these congestions, like this in the X-rays, and APG is also showing the acidosis. So this is the most commonly we should suspect as in PDA.
Yeah, DD is one of the differential. Also, we need to think about sepsis also in such kind of scenario because the baby was on since last 3 days. Baby was on ventilator. Now this X-ray, you can definitely see there is pulmonary overflow is there, pulmonary flooding is there. There is little bit of cardiomegaly. Along with that, on ABG, there is mixed metabolic acidosis as well as respiratory acidosis. So even in case of PDA, you can get metabolic acidosis because of decreased tissue perfusion. So after stabilization, investigations were ordered. Vitals were stable. There was no tachycardia, but on auscultation there was a faint murmur. So our differential, our thinking towards PDA, it was strengthened. Sepsis claim was negative. Again, it was strengthened. There was no anemia. So we can think about there was no pulmonary hemorrhage. Blood gas suggestive of middle gas is impacted. However, KFT was suggestive of increased urea and creatinine. So increased urea and creatinine doesn't mean that it is a kidney disorder. It's because of a less perfusion to the end organs, which is one of the organs is kidney. So this was the report that baby was having large.
Hyperdynamic precordial, then pulse, white pulse pressure, murmur, cardiomegaly, pulmonary congestion, hepatomegaly. These will show that congestion.
That will point towards that baby might be having PDA as a differential diagnosis, and that will be a clinically significant PDA in such scenario.
Yeah.
Yes. And what would be the ECOBAS criteria? I will ask Dr. Amal Pale sir. So what are the ECOBAS criteria for them?
If ductal, a transductal diameter, if it is more than 1.5 mm, then it shows that this is moderate or severe this thing PDA. And this pulmonary over circulation, it will be suggested by LAAO ratio if it is more than 1.4. And then decrease systemic health. It will
That also suggests that you are dealing with a clinically significant PDA. So this question to Dr. Bhupesh, that what should be done immediately to handle this large PDA?
If we are suspecting any heart disease and the PDA which is large, So we should think about the fluid what we are giving. We should titrate the fluid. We should restrict the fluid accordingly. Along with this, as the create was and this increase, we should think about diuretics. Uh, so we should, before with starting with paracetamol and ibuprofen, we should think these two things we should first start it.
So in order to avoid over circulation, in order to decrease the heart rate of this obstruction, it is important to calm the baby. So fluid restriction, before thinking about which drugs to be given, this has to be ordered immediately. Fluid restriction to be up 120 ml per kilo, and sedation analgesia just to decrease the heart rate. Diuretic sometimes may be required. Increasing the PEEP and FiO2 will help to stabilize the baby. So what should be the ideal drug in such scenario when you find metabolic acidosis is there, when you find that increased urea, increased creatinine is there, and you need to treat this PDA. What should be the ideal drug to treat such PDA? Indomethacin, brufen, or paracetamol?
I think given this scenario in this baby with deranged KFT, the most important, the most suitable drug would be paracetamol, because brufen and indomethacin will both have some sort of renal uh, derangement which can further increase. So there's good enough evidence for now for use of paracetamol in such situations.
Also, if you want to compare efficacy of drug, if it is indomethacin versus paracetamol, what is your take on it?
Personally, I'm not a great fan of paracetamol. I've been using brufen quite a lot, and there is sort of mixed evidence till date that whether paracetamol is is equally effective as compared to indomethacin or brufen. But in a scenario like this, given the situation of deranged KFT, you would always like to go with a safer drug, which would be paracetamol.
Also, in case of a paracetamol, oral supplementation of paracetamol if is found to be better as compared to IV paracetamol because of slow drug resorption, and it will stay in the body for a longer period of time, so that the effect to PDA will be more while treating this. Now, infant, so you have treated this PDA, you found that infant was the respiratory disease is getting resolved, so infant was extruded to either CPAP after fluid restriction paracetamol. This baby was stable for next 2 days, reached full feed, but started developing the tachypnea again on day 7 of life. However, along with the respiratory distress, you found that these babies also have intermittent desaturation as well as bradycardia. So, how to evaluate this baby, Dr. Banai, sir?
Um, the baby is already who is sick and on the respiratory support. If it develops further respiratory distress, you would like to think about sepsis first in any case. And the ideal investigation will do a CB, CCRP, and a blood culture. But also, you would like to know baby's gas status. So what is the oxygenation and carbon dioxide level? And that will give you acid-base status of the baby and whether we are developing in some sort of acidosis. Looking at this clinical scenario, I think with a pH of 7.2 and a bicarb of 10, this is a typical age at which babies will have non-anion gap metabolic acidosis, which is very common in preterm babies whose renal system is not mature enough and they are unable to secrete free acid, and that's how they land up into non-anion gap metabolic acidosis. I think that's what this clinical picture looks like.
Yeah. So this is a quite a common diagnosis in preterm babies. Once you rule out sepsis as a cause, and you find that baby is hemodynamically stable with normal lactate, and you are getting acidosis as a cause of increased tachypnea, that would be that with the normal lactate, with normal CRP, with little bit of a stable, that is initially it was also creatinine was 80, now it is also 80 with creatinine 1.1. And if you evaluate this baby's history down the line, you find there was little bit of a polyuria, because mostly in NICUs we generally weigh diaper. So it is very difficult to say whether that diaper weight includes stool or it is not there. So polyuria diagnosis in initial part of a baby sickness level is a little bit difficult. So such kind of scenario of normal anemia metabolic acidosis with the hyperkalemia, it has been explained in preterm babies. It is mostly because of immature tubule as well as the aldosterone insensitivity. So this baby required normal saline bolus with fluid relaxation. Initially, this baby required fluid restriction. Now this baby is requiring fluid relaxation, normal saline bolus, and bicarb correction was given. However, this baby again, after a transient improvement, again went in rest, again having this is a real case scenario I'm talking about. So again, this baby was having respiratory distress, which was persistent with transient improvement for 1 day. But vitals were like now this time were 170 per minute with the baseline heart rate of 150 per minute, normal CRT, blood pressure again white pulse pressure, murmur is not audible now, urine output is 5 ml per kilo per hour. So what could be the cause of this persistent, Dr. Sumi?
So this child initially responded to pharmacological treatment, and we have already ruled out sepsis, pneumonia, and anemia based on the investigations. This child is having acidosis and renal dysfunction. Now, this child is having increased respiratory distress with tachycardia and increased pulse pressure of 26. Though the murmur is not audible, we should think of persistence of PDA or reopening of PDA. So we should do a check 2D echo for this child.
This is mostly missed while treating preterm babies with any kind of drugs for PDA. Check 2D echo is generally not being ordered. So once we form protocol that once PDA is treated, we ourselves should check it that PDA has been closed after the improvement in symptoms, or it has not, or this baby require a long treatment for PDA. So since there was risk for renal injury, this baby was subjected for surgical ligation of a PDA, of a 1 kilo baby at 13 days of life. So immediately post surgical ligation, we also think that if the respiratory distress worsens, again the diagnosis of sepsis comes in our mind. So what are the immediate effects of a post surgical ligation of this PDA? Dr. Ganai sir.
Because we are suddenly ligating the duct, the left ventricular output, the left ventricle faces an severe afterload, as well as because the blood is not coming anyway from the duct now, the preload also is decreasing in the left ventricle. So basically, the left ventricular output goes down suddenly, and babies can become severely hypertensive. And because of the pulmonary congestion, they will again also develop tachypnea and respiratory distress. So metabolic acidosis can again be there. So sudden onset hypotension and reduced left ventricular output. That's how this baby is present, and it's been labeled as post-surgical ligation syndrome also. And you have to be very vigilant post ligation because these babies can suddenly collapse because of this. And the treatment has been to improve the left ventricular output, and so you have to balance your fluid very well, fluids, and as well as people have tried milrinone as a prophylaxis. So babies who have been severely ill and then they go undergo pedialigation, prophylactic use of milrinone has been shown to reduce this syndrome by almost 1/3. So that has been the recent studies which have shown benefit of it.
Point well taken, sir. So now this baby has been treated off PDA and has taken care of his renal parameters also. Now, however, this baby was gradually weaned from ventilator, then from CPAP. This baby a post-ligation required ventilator. Instead of support was given for 2 days. Then baby was shifted from ventilator to CPAP. But still, FIT requirement of 30% is required. What was the possibility of this FIT requirement, Dr. Mohan sir?
As we have excluded the sepsis, heart disease, we have treated it, and still the baby has FO2 requirement. As initially we have given ventilator supports, we now CPAP, oxygen, then again on ventilator. That means the lung compliance is not so good. It mostly lung that not working properly. That's so we commonly thinks about chronic lung disease. That most after exclusion, they all think the bronchopulmonary dysplasia we should think in mind. So that O2 requirement is persistent and baby has other marker as in normal range.
So, bronchopulmonary dysplasia is very well limited in preterm babies, and generally this happens with the prolonged use of oxygen as well as prolonged ventilation, and there are various other risk factors. So, how to manage this baby is definitely suffering from is having evolving BPD or BPD as a diagnosis. So, how to diagnose BPD and what are the management strategies to treat such kind of BPD in nutshell, Dr.
As
Bruce.
we know, the 30-50% that premature baby was found that bronchopulmonary dysplasia, and by definition, those baby requiring more than 28 days for O2 oxygen. That category is before less than 32 and after 32 weeks babies. The post-menstrual age at 36 weeks, we should calculate the requirement of O2. That those require the minimal O2 that is more than 21%, that we categorize mild, and those less than 30% as moderate, and those requiring the supports, the we should label it as severe bipolar bronchopulmonary dysplasias. So that babies after 20 or 56 days we give the oxygen requirement as assessment of this. And
How to what are the management strategies?
we should minimize the that invasive ventilations, proper fluid management, early initiation of breast milk, and early start of caffeine. That will help to manage these BPD.
Also, any role of dexamethasone?
Yeah, steroid we can give the aldosterone, hydrocortisone, and glucocorticoids also we can use in this.
Yeah, just to remodel the injured lung, dexamethasone is recommended with the proper doses as per target plan. So this is how we discharge our preterm neoid with a lot of a struggle from an ICU without any ROP, without any kind of neurological impairment. Now coming to case 2, this is 35 days old.